Good evening, everyone. My name is Mark Whitmore. I'm the chair of the board of Crohn's and Colitis Canada. With this webinar, as with others, we're using this opportunity to introduce you to different parts of our organization so that you can learn more about Crohn's and Colitis Canada. A little bit about myself. I got involved with Crohn's and Colitis 9 years ago when my son Grant was diagnosed with Crohn's. Professionally, I used to be a senior partner with Deloitte, and 2 years ago I left Deloitte to farm full time. We farm down here by Turkey Point, Ontario. We grow hops for the craft beer industry, hazelnuts for the baking industry, and we grow horseradish for our own business, which is called Dennis's Horseradish. So like you, I'm personally impacted by IBD. My son lives with it all the time. Most recently had to deal with him going into the hospital with regards to a new biologic, which unfortunately he had a reaction to. And so fortunately he's home from that, but we certainly understand what it means to live with this all the time. And as a caregiver, I understand particularly what it means during COVID, and the concerns and the angst that everybody has about going into hospitals and having to deal with this other level of challenge on top of IBD that we already have. But it's great to have information available from seminars like this and webinars like this to help us understand the best way to cope with it going forward. Every day we have a lot of people reaching out to us to help them, and not only to deal with IBD, but dealing with it during the COVID situation. And now we've helped 4 times as many people than we did this time last year. And we've had an additional 100,000 visitors to our website. And also this year, we've because of COVID and the way that organizations have to respond to it, we've done a lot more webinars, and in fact, we've done 5 times as many as we did this time last year. So it's really helpful to to have the community provide feedback and give reactions to these, and we're happy to be the organization that you look to for information on this. And so while a lot has changed this year, a lot of things haven't changed. We're still very committed to finding a cure and to helping those that live with it, because Crohn's and Colitis doesn't care about COVID. The disease continues, and so we need to continue to do the work. I'm fortunate that I'm the chair now of an organization that has been around since 1974 with one very specific focus, which is to find a cure, as well as to help patients that live with it. And together we've made a lot of great advances. We've been fortunate over the years to raise a lot of money to support research, and you'll hear about some of that, and they have been hearing a lot about that. And it's been a tough time this past year. Like all health charities, we've been impacted by it. But we've been fortunate that we were in fairly good shape going into the COVID situation, and we continue to work hard to raise funds that we can continue to support the research that we've already committed to, as well as to continue to support new research that's important to us going forward. So we're very committed to our cause. We're very committed to finding a cure, and we're going to keep working hard for that. Tonight is our 18th webinar. We'll be hosting these webinars as long as you need them, and we can increase the frequency if that's of value to you. As always, this information is available on our website at crohnsandcolitiscanada.ca. We hope again that you can join us for our next one, which is being hosted in December. For our upcoming Gutsy Learning series on November 26th, we're going to have Dr. John Marshall. We'll discuss managing symptoms and complications of IBD. And on November 29th, we're hosting the Jacqueline Fisher Education Symposium. And this features several IBD experts who are going to talk about preparing for GI appointments, transition from pediatric to adult care, and other life events. So we're hopeful that you can join us for these great information sessions. And with that, I also want to thank the task force that's been giving us advice and counsel on these policies and recommendations. And you can see the list on the screen there, the great input that we're getting from this with this council here. And then finally, I want to thank today's panelists. We have a number of panelists. We have, do we have it there? Yeah, we do. Great. So we have Dr. Manaseh Agrawal, Dr. Erica Brenner, and Dr. Jennifer Jones. And you're going to find this session really interesting, where they're going to be talking about the latest findings from the SECURE IBD Registry. And so finally, I'd also like to thank our moderators, who I both know very well. Dr. Gil Kaplan, a lot of you, of course, would know as well. Gil, thank you. Good to see you. Professor of Medicine at the University of Calgary and adult gastroenterologist and epidemiologist. And he most recently was the past chair of the Scientific Medical Advisory Council, and with that was also on the board of Crohn's and Colitis Canada, and will be stepping down from that. So Gil, thank you for what you continue to do for the CCC community and the Crohn's and Colitis community, and for the great work you've done with us on the board. Also tonight we have Dr. Eric Benchimol. Eric, good to see you again. He is a professor at University of Toronto and a pediatric gastroenterologist at SickKids in Toronto. And he is recently stepping up to be the chair of the Scientific Medical Advisory Council, and with that, we'll be joining the board of Crohn's and Colitis Canada. So, Gil, great to have had you on board, and Eric, great to have you coming on board. So, thank you, gentlemen, for everything you do, and over to you now for the rest of the evening. And thanks everyone for joining us tonight.
Thanks a lot, Mark.
Thanks very much, Mark.
Yeah, I feel, Eric, you and I have been partners in crime since this, well before the pandemic, but definitely over the past 8 months. And I can't believe this is our 18th webinar now. And things have definitely, a lot of things have changed between the last one and this one.
Yeah, no, it's been interesting, that's for sure. You know, there's been good times certainly over the summer, and then not so good times, especially at the beginning when people were very scared. But I think we're starting to get a grip on things, and there's certainly, as you'll say in a few minutes, a light at the end of the tunnel, it seems.
Well, and with that, I just thought I would do a small, like 5-minute presentation just before we bring in Erica and Manassi to talk about the SECURE IBD Registry, to just touch upon, I think, the two biggest things that have impacted COVID and the IBD world, and that's really been the second wave, and then the announcements of the new mRNA vaccine. So, Sarah, if I could take the screen. So hopefully everyone can see my screen here. Okay, perfect. So after living through the first wave of the pandemic during the spring of 2020, the summer saw low cases of COVID. Unfortunately, over the past few months, we've observed rising cases of COVID in Canada and throughout the world. There are more cases today than during the peak of the first wave. And we're still in the upswing of this second wave with no clear idea when it will end. Epidemiologists have labeled the next few months as the dark winter of COVID. While we're all living through this dark winter, we can also see light at the end of the tunnel. Last week, 2 novel mRNA-based vaccines against COVID were announced with greater than 90% effectiveness. And I just want to explore the gravity of the second COVID wave in Canada, and then also share uplifting news on the potential impact of these novel mRNA vaccines. So how long will this pandemic last? So in previous webinars, I shared with you this slide, and we talked about different potential scenarios and how the pandemic could potentially play out. Now we can see that the COVID pandemic has similarities to the 1918 flu pandemic. In both 1918 and 2020, we saw a spring wave followed by lower cases in the summer, and a second fall winter wave that's considerably larger than the spring. Now, how high will this peak go over the next few months entirely depends on what we do as a society and within our own homes. Through 18 webinars dating back from March 19th to 8 months later, we've seen cases of COVID in the world grow from 230,000 to over 56 million today. On March 19th, 782 Canadians were diagnosed with COVID, and today there are over 300,000. The SECURE IBD Registry, which we'll learn more about later in the webinar, is an international database of individuals with IBD who tested positive for COVID. On March 19th, 21 patients with IBD were in that database. Today, there are over 3,100 cases. This graph shows the daily number of cases of COVID diagnosed over the last 11 months in Canada. During the first wave of the pandemic between March and May, daily cases were exceeding over roughly 2,000 diagnoses a day. Through the summer, daily cases of COVID waned, but have subsequently picked up dramatically during the fall, with now over 5,000 cases a day being reported across Canada. How high will this number go depends on what we do as a collective over the next few weeks. Now, the orange line represents daily death from COVID, with the scale on the right-hand side of the graph. Important to recognize that death lags diagnosis by roughly 2 weeks. Similarly, people infected this week will not be diagnosed for another 1 to 2 weeks. We've never been closer to overwhelming our healthcare systems as we are today. As a consequence, regions all over the country are tightening restrictions. While the second wave is truly worrisome, there are signs for optimism. A diagnosis of COVID today is different from one that was diagnosed back in the spring, when our knowledge of the virus and treatments were limited. The sacrifices we have all made in the spring and care that we've taken over the past 6 months bought us time for our healthcare systems to prepare for this second wave. Moreover, we've made major medical breakthroughs. In July, a randomized control study in the New England Journal of Medicine showed that dexamethasone reduced death in critically ill patients. In August, we treated people with antibodies from plasma taken from those who recovered from COVID. In October, we got firm evidence that remdesivir is an antiviral agent that targets SARS-CoV-2, the virus that causes COVID-19. And in the last week, 2 landmark announcements were made showing novel mRNA vaccines both had greater than 90% effectiveness in preventing COVID. So what are mRNA vaccines? These are novel vaccines that were completely different than traditional vaccines that inject either a diluted form of the virus or proteins of a virus. Both mRNA vaccines target the spike protein that sits on the surface of the virus. Scientists have isolated the genetic sequence for the virus spike protein and synthesized its mRNA sequence. mRNA provides the instructions that cells use to make the spike protein. The synthetic mRNA is packaged in a lipid nanoparticle, and that delivers the mRNA instructions to a cell. Once inside the cell's machinery follows the mRNA instructions to produce the viral protein. And this viral protein, the spike protein, is displayed on the surface of the cell, which then stimulates an immune response. And this is novel. This is a completely new way of a vaccine being developed. Now, what does 94.5% effective vaccine mean? Well, based on a press release, and this is important because we don't have the full data, that hasn't been published yet. But based on a press release, we learned that the Moderna vaccine was given to 15,000 people, whereby 5 developed COVID-19, but none were seriously ill. Another 15,000 people were given a placebo shot, and 90 developed COVID, with 11 being severely ill. To date, no clear side effects have been reported with these new vaccines, so we are waiting new data. The news is very promising. While we're all waiting to see the full data, it appears that we will have vaccines in 2021. Now, I showed this graphic from the Washington Post during my first presentation back on March 19th. The video illustrates how physical distancing, being that stationary dot, flattens the curve of COVID. This is what we did in the spring of 2020. I realize how frustrating and the hardships we've all endured as provinces have added greater restrictions to our livelihoods. But restrictions that we take on today are the bridge to the vaccines of 2021. And a vaccine is a stationary dot. A vaccine will stop COVID in the same way that social distancing does, but it means that you don't have to be that stationary dot. Today, we're all facing a dark winter, but one with light at the end of the tunnel. And with that, I'll grab the screen back to Sarah and have the huge honor and privilege to be able to introduce our 2 guest speakers about the SECURE IBD Registry. First, I want to introduce Dr. Manasi Agarwal. She's an instructor in medicine at the SickKids School of Medicine at Mount Sinai, New York. After completing an advanced IBD fellowship at Mount Sinai in New York, she's pursuing a master's of biostatistics at Columbia University. Dr. Agarwal is a member of the steering committee of the SECURE IBD Registry. It's an international-based database to study characteristics and outcomes of COVID-19 in patients with IBD. In addition to clinical management of IBD patients, Dr. Agarwal is pursuing an academic career in IBD epidemiology, focusing on environmental causes of IBD and the impact of IBD on minority groups. Manasi, thank you so much for joining us today. Next, I'd like to introduce Dr. Erica Brenner. She's a 3rd-year pediatric GI fellow at the University of North Carolina at Chapel Hill. She's pursuing a master's in clinical research at UNC. Dr. Brenner is going to start an advanced IBD fellowship at UNC in 2021. She's one of the co-founders of the SECURE IBD Registry, and she aspires to pursue a clinical and epidemiology career while caring for children with IBD. Welcome, Erica. And I will pass on the webinar to you guys. We're looking forward to your presentation. Thank you.
Hi, everyone, and thank you for joining us today, and thank you to the organizers for having us. So COVID-19 and IBD, as Dr. Kaplan mentioned, we're struggling with it, but there is light at the end of the tunnel. In the meantime, what it is that we need to know, both in terms of patients as well as caregivers. Increasing risk of hospitalization, need for intensive care, need for mechanical ventilation, and conditions such as asthma, hypertension, diabetes, kidney disease have been well studied. Additionally, we have started to identify that corticosteroids, which the patients may be on at baseline, as well as medications that suppress the immune system, increase the risk of various infections, possibly including COVID-19. Which brings us to the very important question for us and for all of our patients: what about the impact of IBD? Is everyone still able to see my screen?
Yes.
Let's see, we are able to
Okay,
see your screen, but I think there's been some audio issues.
okay.
I can hear you right now, though.
Okay, so were you able to hear the first part?
We missed some of it, so maybe start from the beginning of this slide.
Okay, sorry about that, everyone. Technical difficulties. So as I had started to say, we're increasingly identifying the risk factors associated with severe COVID-19, meaning COVID-19 hospitalization, ICU admission, mechanical ventilation, and we're understanding that the presence of comorbid conditions, especially if it is uncontrolled, is an important risk factor. Factors such as asthma, hypertension, heart disease, obesity, they're all risk factors for severe COVID outcomes. Immune-mediating therapies suppress the immune system and increase our vulnerability to infections, which is why IBD is something that we all worry about, we as physicians and our patients and caregivers as well. IBD is a chronic health condition, and it is treated with immune suppressing treatments, different classes of medications, as you all very well know, as well as corticosteroids during flares. Therefore, IBD is a very important condition to get a grasp on with respect to COVID-19. So in order to answer all of these questions, we established the SECURE IBD Registry. It stands for Surveillance Epidemiology of Coronavirus Under Research Exclusion, and it was founded by Dr. Brenner and Dr. Kaplan at University of North Carolina, and Dr. Ungaro and Dr. Columbell at Mount Sinai. And the purpose was to very rapidly define the impact of COVID-19 on our patients with IBD, as well as evaluate factors such as age, other health conditions, and very importantly, IBD treatments that impact COVID-19, and how is it that we can best take care of our IBD patients. So this is the SECURE IBD database. It is a web-based database through a website, and this is what it looks like. It's a very simple survey. It takes less than a few minutes to complete, and it is filled out by healthcare providers. And we encourage healthcare providers to fill out this survey after the COVID infection has resolved, so we have a clear understanding of the course of the disease. We collect information on patient location, demographics, IBD characteristics, other health conditions, COVID treatments, and COVID outcomes. These data are collected in a secure encrypted server in the University of North Carolina, and all of these data are de-identified and in compliance with HIPAA standards. So this is a graph of the number of cases and its trajectory that have been recorded in SECURE IBD since its inception in March. we have nearly 3,200 cases. And as you can see, this graph parallels the global pandemic and changes in the global pandemic, meaning that this graph was steeper in the spring with a slight flattening over the summer, and it's getting steeper again. We have data from 62 different countries, and this here is an interactive map of SECURE IBD, which was developed by Dr. Kaplan and his excellent team. It's available on our website, and it gives us a sense of how many cases these how many cases are occurring in different countries, and this also reflects the burden of COVID-19 and IBD in different countries globally. So which patients are at highest risk of adverse outcomes in terms of COVID-19? So this is stratified data by age, which Dr. Brenner reported in the first publication from SECURE IBD. And as you can see here, as you go down the different age groups, you can clearly see that there is a trend for death and more severe outcomes occurring in advancing age groups, especially in persons over 65 years of age. Similarly, outcomes by severe health conditions also tell us a story in that as the number of comorbid conditions increase, the risk of severe COVID, including ICU stay, ventilation, etc., go up. And these are very similar to the overall risk factors for COVID that we see in the general population, that with advancing age and with the presence of other comorbid conditions, the risk of adverse outcomes goes up. I will now hand it over to my colleague, Dr. Brenner, to discuss other findings from the registry.
Thank you, Dr. Agrawal. Next slide, please. So I'm going to talk a little bit about COVID risk in terms of different IBD medications. This chart shows different IBD medications, and similar to the ones that Dr. Agrawal showed, the columns represent individuals who passed away from COVID-19 and individuals who developed severe COVID, which we've defined either as need for an ICU stay, use of a mechanical ventilator, or death. And next slide, please. I want to point your attention to the two numbers circled on this slide. And specifically, we have found that patients who are on oral or parenteral steroid medicines have a higher risk of severe COVID, and you can see 18% of those individuals on that medicine developed severe COVID. And this is in contrast to the other number that's circled, and that is in relation to the anti-TNF biologic therapy, and specifically monotherapy. So that means without a thiopurine like 6-mercaptopurine or azathioprine, or without methotrexate. If you look on the next row, the anti-TNF combination therapy, there is a slightly increased risk of severe COVID among individuals who are on those medications. And when we've looked more at that, we found that really individuals who are on the anti-TNF biologic therapy with a thiopurine have a higher risk of severe COVID, and that the anti-TNF with methotrexate appears to be safe. Next slide. This is a table specifically highlighting outcomes among patients who are on tofacitinib. And all of the different rows are different outcomes among individuals who developed COVID. And the middle column is tofacitinib, and then the column to the right of that is all other IBD medications. And if you look at the bottom two rows, so either death or severe COVID-19, the numbers are essentially identical between tofacitinib and between other IBD type medications. So really we see no difference. So from this sort of hot off the press data, it appears that individuals who are on tofacitinib are at no higher risk than individuals with IBD who are on other medications. Next slide. So overall, our SECURE IBD data shows that, like in the general population, advancing age and other health conditions are significant risk factors for severe disease. We've also found that systemic steroids are associated with worse COVID outcomes, and in contrast, anti-TNF biologic therapy appears to be safe. We still need more data to further understand the safety of other drug classes, and this includes the aminosalicylates and anti-TNF combination therapy. Next slide. I wanted to spend a little bit of time talking about children with inflammatory bowel disease, because as we know, kids are not just small adults. And very reassuringly, we've found that children with IBD are a relatively low risk of severe COVID, even when receiving immune suppressive treatments. Next slide. So our SECURE IBD team teamed up with the Pediatric IBD Porto Group team, who launched a parallel, specifically pediatric registry to look at outcomes among children with IBD who develop COVID-19. And together we pooled our data to look at how children do if they develop this virus. Next slide. So in total, we studied 209 children ages less than or equal to 18 from 23 different countries. Approximately half were on anti-TNF biologic therapy, and specifically monotherapy, and 23% were either taking sulfasalazine or mesalamine. And overall, our outcome data, again, were very reassuring. There were no deaths among all 209 children studied. 14 or 7% were hospitalized, which is markedly lower than the approximately 25% hospitalization rate in the entire SECURE IBD database, which includes adults. Of the 14 who were hospitalized, 2 or 1% required care in an intensive care unit and use of a respirator, but both ultimately recovered. Next slide. So overall, and I won't go too in-depth on these different medications, but our recommendations far and away is to stay on your IBD medications during the pandemic and look to guidance from, first and foremost, your IBD provider, and then also from the Crohn's and Colitis Canada website, which you'll hear more about this evening. Next slide. There are 2 caveats to staying on your IBD medications, and that includes if you're on systemic corticosteroids, then it's important to talk to your doctor about whether you would want to decrease those medicines. And if you develop COVID-19, in some cases, it may be indicated to hold your medication, but this is a decision that you should really make in consultation with your provider. Next slide. So overall, as a patient or a family member of someone with inflammatory bowel disease, you can help by telling your IBD provider if you have symptoms of COVID-19. You can also encourage your provider to report cases of COVID in their patients to the SECURE IBD database, found at covidibd.org. And finally, you can participate in IBD Partners, which is an IBD patient-powered research network that can be found at www.ibdpartners.org. Next slide. And this is the tab on our website where you can find more information about COVID-19 and IBD. And again, if you go on the Crohn's and Colitis Canada website, you can access more important information about COVID-19 and IBD. Next slide. So thank you for having me and Dr. Agrawal, and of course, thank you to all of our reporting providers and our partners shown on this slide and many organizations listed on our website. Next slide.
Yeah, so you stole my words, Erica. Thank you. That was great. Thank you very much. But yes, please do put some of your comments into the chat box, your questions into the chat box. We received questions from people who enrolled already, so we have a list of things that we know that you want to ask. But before we get to the panel and introduce Dr. Jones, I just want to thank Dr. Brenner and Dr. Agrawal as well. But I wanted to show the guidance document, and just because we want to put it into context of what you have recommended or what you found in SECURE IBD, I want to show sort of how those recommendations were put into action by the task force, and remind people to go to crohnsandcolitis.ca/COVID-19. And if you scroll down to the guidance section, that's really what we're going to talk about. and then the are you at risk section, it really does put into context sort of low risk, medium risk, and high risk people with IBD, and puts all of this data that we've gotten from SECURE IBD into action. And so I'll start with the high risk group down here. I'm sure most of you remember, you may have been on previous webinars where I've shown this. This hasn't changed. The main reason we put people into a high risk category is either if they're over 65 in any situation at all, or if they're under 65 and on steroids. As Dr. Brenner and Dr. Agarwal suggested, that is puts you in a high risk category for severe outcomes with IBD. And then having active, moderate, or severe active inflammation, moderate or severe malnutrition, and requirement for IV nutrition. In all of those cases, we recommend staying home and self-isolating. In the medium risk category is anybody under 65 taking that category that Dr. Brenner mentioned, the immunosuppressive medications, including azathioprine, Imuran, 6-MP, or methotrexate, the biologics, all types of biologics, anti-TNF, anti-IL-12/23, and anti-leukocyte migration biologics, and the JAK inhibitor molecules. Tofacitinib was also in the medium risk category. And then if you're not on those immunosuppressive or biologic medications and you're under 65 and your IBD is in remission, you're considered in the general risk category. It doesn't mean go out to a bar and have a drink. It means follow the public health guidance, which is really physical distancing, wearing a mask, washing your hands frequently, and not going to work or school if you have symptoms of COVID-19. So one of the things that we met about last week, the task force met to discuss the new data from SECURE IBD and to decide whether this reassuring data saying that the biologics, the anti-TNFs and the other biologics actually seem not to predispose people to a higher risk of severe COVID-19, ICU admission, ventilation, or death. So in that case, should we be moving people on these biologics to the low risk category, to the general public health risk category? And while people were very reassured and all the GI physicians felt that in general, people on the biologics, if they're in remission, can probably go and engage in life with public health guidelines, taking into account physical distancing and so on, they don't necessarily need to stay home and not work. We don't really know much about how these biologics impact on infectivity, right? So we don't know yet. SECURE IBD is a cross-sectional study at the time somebody gets COVID-19. It doesn't tell us whether the biologics make you at increased, decrease, or the same risk of getting infected in the first place. We just know that people, once they get infected, do fine. So we decided to keep this in the medium risk category. I think until more data is out, there certainly has been some data that have suggested that these biologics do not put you at increased risk of getting infected, but it's very preliminary data. Only one study that I can think of from Denmark in IBD patients. But so we're still waiting for more information on that sort of, does it cause increased infectivity? You know, even though it seems to be safe to continue on if you get COVID-19. So that's what I wanted to show you. I'm going to stop sharing my screen and I'll invite the panelists to come back on their webcams. There we go. And I want to introduce the final panelist tonight, and that's Dr. Jennifer Jones, who's been on our webinar before. Dr. Jones is an associate professor of medicine at Dalhousie University and team lead of the, team lead of the Nova Scotia Collaborative IBD program at Queen Elizabeth II Health Sciences Center in Halifax. She completed gastroenterology training at Dalhousie University in 2004 and went on to do a clinical and research fellowship in IBD at the Mayo Clinic in Rochester. Then a master's of epidemiology while working at her IBD program at University of Calgary. 2008, she started as an assistant professor at the University of Saskatchewan. And then in 2014, returned to Halifax. So she's been sort of all over northern North America. You really should have gone south to warmer weather, eh? But she returned to 2014 to Halifax, and her clinical and research interests include quality improvement initiatives and patient-centered programs, care access, national interventions, and same as Gil and I, the use of population-based data to evaluate IBD outcomes. So welcome back, Dr. Jones. And I'm going to start with a question for Dr. Brenner, who, as mentioned, is a pediatric gastroenterology fellow, which means she's still a trainee, not yet a full-fledged gastroenterologist, third year, so soon. In Canada, you actually only need 2 years to write your Royal College exam. So you would be in Canada, but you need a 3rd year in the United States. And what I wanted to know is how did you decide to build the SECURE IBD Registry? How did it come to fruition? You kind of caught lightning in a bottle. How did that happen? That's for you, Erica.
There we go.
Oh, there we go. There you are.
Mute button. Yeah, so it all started with a phone call late at night on a Thursday in March from my mentor, Mike Kaplan, saying, you know, we're early in the course, and you know, we don't know what is going to happen with COVID-19. We don't know how bad this is going to be. And he was telling me, I was thinking, we have so many of our patients on immune suppressive medicines, and we don't know if they get COVID, how they are going to do, whether they're going to have outcomes that are worse than the general population. And I think there's a huge opportunity here for us to do something that would be quick and gather data. And, you know, I think we were thinking more nationally, and then we're pleased and amazed that this became an international, a global effort. So I said, yeah, absolutely, I'm on board. How can we build this project? So that was where the troubleshooting began. And then we have this amazing clinical and translational research institute, sort of think tank at the University of North Carolina. So we met with different folks there, and very rapidly they taught me how to build a REDCap survey and create a website. And then sort of as we were having this idea, our collaborators at Mount Sinai were sort of thinking along similar lines, and it was the International Organization for the Study of IBD who brought us together initially and said, I think that you should both talk to each other and maybe you can team up. And we did, and it's just been an absolutely amazing collaboration. I think Monty can speak to that as well. So it was really from a phone call from Mike, and then some help at UNC, and then GI organizations bringing us together with our New York City collaborators.
Yeah, man,
yeah, it was such a hugely important initiative, I think, to IBD patients around the world and to physicians and nurses as well. Yeah, Mansi, we were going to ask you sort of, I guess this started sort of at the height of the first wave in New York City, eh? Is that what prompted your involvement as well?
Yes, so New York City was one of the earliest places in the country to be affected, and not just affected, the exponential rise. It was just unbelievable and very hard to cope with. But actually, my mentor, Jean-Fred Colombel, sort of saw this coming. Like Mike Kaplan, he predicted that this is going to be a real problem, and especially for our IBD patients who are, you know, many of whom are very sick. This is a chronic health condition, and very importantly, they're on these immune suppressing medications. On the one hand, if you stop these medications, their disease flares, which puts them at risk for bad outcomes. And on the other hand, if you continue these medications, that increases their susceptibility to infections. So he called it, and he talked to us, and he told us that this is something we must keep an eye out for, and we must look into. And then we had the good fortune to collide with Erica and Mike, and SECURE IBD happened. And we just can't believe, you know, how great this effort has been and how much we're learning along the way.
Yeah, and that's actually really similar to how the COVID and IBD task force got started as well, right in the beginning of March. Eric and I were on the Scientific Medical Advisory Council for Colitis Canada, and as we saw everything unfold, we were just realizing all of the challenges that were going to happen to the world, to Canada, and how uniquely impacted patients with IBD were going to be, and that led us to strike a task force. And in the early days, all of our recommendations were based on extrapolating information from what we knew about other viruses, or what we like expert opinion, what we think might happen. This is a brand new virus. We had no frame of reference, and it really was SECURE IBD Registry and a few other data sources that came by that finally gave us some key answers that as Eric showed earlier, you know, adapted our recommendations thereafter. Manis, I just wanted to talk about or to touch about something that you talked about in your presentation around risk factors for COVID. And I just wanted to go a little bit more in depth about what are some of the big risk factors that put you at higher risk for a more severe complication if you get into COVID. In our webinars, we actually do have an older population. There's a lot of individuals who are over the age of 60 who are watching this, and then they have some of the comorbidities that you mentioned, even if they're not necessarily linked to their IBD, but they might have hypertension and diabetes. And just want to see if you could give us a bit more explanation about those risk factors and what you're telling your patients who have risk factors and are in their 60s.
Absolutely. So as we found with SECURE and multiple other databases among non-IBD patients have shown that age, advancing age over 60 is an important risk factor to keep in mind, as are a multitude of comorbid conditions. So for such patients, I think one of the most important things we tell them is to make sure that their IBD is in remission and other diseases are well controlled. And two, just the usual precautions which we take ourselves and tell other folks to maintain distancing, to wear a mask, frequent hand washing, avoiding closed spaces. So those are all important things to take into account, and certainly making sure that persons they come in contact with are doing well. And if anybody has any concern or concerning symptoms, then they should stay isolated in quarantine. And then the other aspect of this is to make sure that we've optimized IBD treatment. That is, we make sure the patients are not on corticosteroids and they continue their other medications, because as Erica mentioned, biologics such as anti-TNFs, etc., they don't put us at increased risk for bad COVID outcomes. It's corticosteroids that do that. So it's important to make sure IBD is in remission and corticosteroids are minimized.
And Manasi, part of your research is on minorities, ethnicities, people who have lower socioeconomic status. And just out of curiosity, what have you found about those types of risk factors and the impact of COVID?
Yeah, so that's a very interesting variable that Erica and I and rest of our team are looking into right now. And sadly, minority groups are more susceptible to adverse COVID outcomes. I mean, in the US, minority groups are susceptible to adverse outcomes and more severe outcomes with respect to most chronic illnesses. And it's also true for COVID. So we are doing this project right now, looking at the impact of race and ethnicity on severe COVID outcomes. And we think there is some signal there in that if you belong to a minority group, such as among Hispanic and Black individuals, we are finding that the risk of hospitalization is higher. And we hope to be able to publish our data soon. We think part of the reason why this happens is because of comorbid conditions, because patients in minority groups often have a higher number of comorbid conditions, perhaps may not be as well controlled. And I think the second aspect of that is access to care. And in the US, we know that in terms of access to care, access to resources, with the root cause of health policy and structural racism, etc. There are a multitude of different causes, but all of these have impacted outcomes in minority groups. And I think the other thing also to consider is that SECURE Registry captures data from providers who reported themselves. So these data are a little bit skewed towards more severe outcomes.
Okay, thank you. And Jen, just bringing you into the dialogue, Manasi had mentioned that corticosteroids has been seen as a consistent risk factor. So if you're needing to be on a higher dose of prednisone, you're more likely to have bad outcomes. But on the flip side of that, I was showing data earlier about dexamethasone, which is a steroid, which was one of the first randomized control studies that when they used it in people who were sick in a hospital actually helped mortality. And just was hoping that's sometimes a point of confusion. I'm just hoping you kind of get your thoughts on steroids and IBD and their impact as a risk factor.
Sure, yeah, and it certainly raised a lot of concern amongst patient group that I follow as well in my practice. And I still don't know, the complete answer, but I think whenever you're looking and trying to interpret the difference in the data and the magnitude of risk that we've observed in those RCTs that you talked about, and in the IBD population and SECURE registry, it's important to think about, the patient populations that have been studied in these studies. It's also important to think about the condition under study and also the disease course and when in the course this medication has been tried. So particularly in the course of the dexamethasone studies, those were really studying patients with severe COVID. We're talking about patients who are hospitalized on supplementary oxygen or requiring mechanical ventilation. So they were sort of at the latter end of the spectrum in terms of severity and disease course with COVID-19, and appeared to benefit from the corticosteroid. And that could be for multiple reasons. It could be that these individuals had developed something that we call a cytokine storm. And essentially what that is that when our bodies encounter a pathogen that we don't recognize, it ramps up and sends out chemical messengers, which are basically like an army of immune messengers that recruit more immune-mediated cells that stimulate more immune responses. And when that becomes dysregulated and overly exaggerated, it takes on a life of its own. It can cause a lot of cell death and end organ damage, particularly in the lungs. And it may be that in that setting where people are on the brink or in the course of a cytokine storm, that steroids are protective. If we look at, prednisone studied in a population of patients with IBD who have acquired COVID-19 potentially earlier on in the disease course, it may be that the corticosteroids are harmful from an infection perspective and allowing the infection to breed more out of control. It could also just be that steroids are a marker for more severe disease course, because patients who are unwell and have poorly controlled disease are far more likely to be on higher doses of systemic corticosteroids. So I don't think that the two observations are completely, it doesn't mean that they don't make sense. What it means is that you have to interpret the observations in the context of the patients being studied and their circumstances, basically.
Thanks, Jen. And another question for you, Jen. Why is it important that patients with IBD stay on biologics and not stop their meds?
Yeah, I mean, so we've all just heard about, very eloquently spelled out by Dr. Brenner and Agrawal, that basically what the risk factors are for severe COVID. And if you think about it, we want our patients to stay in remission. And if our patients are in remission on biologics, like anti-TNF agents, anti-interleukin 12/23 agents like Stelara, gut selective agents like vedolizumab, et cetera, if they are in remission, we want them to stay there. And the last thing we want them to do is to go off these medications, feeling that for some reason they may put them at risk for more severe COVID. And we certainly know that doesn't appear to be the case based on the data that was presented. And if they go off these medications and flare, then they're going to put themselves at risk of potentially exposing themselves to those very risk factors that may actually put you at increased risk of severe COVID-19. So we don't want our patients going to hospital. We don't want our patients having to go on higher doses of steroids to get disease back under control, and potentially increasing the risk of undernutrition, et cetera. The list goes on. So very important to stay on medications, particularly biologics, that may very well be keeping your disease in control. And as you saw, although it's still early, there seems to be, and there could potentially be, a protective effect of some of these biologic agents, such as anti-TNF agents.
Very well said. I'll pivot, since we're talking about biologics, to Dr. Brenner. This is a question from the audience that I thought was a good one. I don't know if there's an answer, but it was a question about a child who's on 2 biologics at the same time. This is certainly not the standard, although it is occurring more and more often, more and more reports of people being on 2 biologics. What would you tell the parent of a child about back to school, or even if it's an adult on 2 biologics? Is it safe for them to go to work?
Yeah, so that's a tough one, because as you mentioned, it's not common, but it's coming up more and more. And I'll have to sort of couch my answer to say that we have not looked at this in the SECURE IBD registry, and largely because we don't have that many cases reported. Last time I looked, we didn't have any cases reported on dual biologics in pediatrics. So my recommendation would be largely based on sort of my overall understanding of the pandemic and risks. And I would be more cautious with that patient than with another, because you are on now 2 immune suppressing agents. So, you know, I would say I would be treating that patient more like they're a patient who's on systemic steroids. But that's really coming from my experience and not from data from the SECURE IBD database, because again, we don't have that right now. But it's a great question.
I tend to agree, and I think it's really important that people speak to their physicians about this. But does the panel agree? Gil, you were going to say something?
Yeah, no, because you know, it's interesting that someone asked about their child. It's something that has been a relatively new practice, something that we're doing a lot more in adults. And what, you know, 5 years ago we had Remicade and we had Humira, and they both worked on the same mechanism of action. And so if they stopped working, you know, we really were limited what we could do from a biologic. But now there's been a plethora of new biologics that work on completely different mechanisms. And what it first allowed us to do was to take somebody who stopped, where Humira stopped working, and then try a new mechanism, Entyvio or Stelara, for example. And now what we're realizing, as we've gotten 5 years into many of these therapies, is that sometimes there's escape mechanisms in the immune system. And so now if we actually had 2 different mechanisms, we can recapture some of that response that was lost. But of course, the immune system is getting suppressed. And then if you add steroids on top of that, you could sometimes be on 3 different drugs that suppress the immune system. And so I totally agree with Erica, is that while we don't have data to understand what happens in those situations, we want to be more careful with that population. And in fact, Erica, I actually have kind of a question for you on the other spectrum. So the other spectrum are the mesalamine drugs that mechanistically don't suppress the immune system systemically, meaning they have an anti-inflammatory effect inside the bowel where they treat ulcerative colitis, for example, but they don't really suppress the immune system systemically. And in Canada, we have 4 mesalamine agents for the audience. It's Asacol, Salvolc, Mesavan, and Pentasa. And just for patients on those medications, it's a little bit surprising that they found it was a risk factor. I just wanted to get a sense of why you think mesalamine came up as a potential risk factor.
Yeah, so that is such a good question and has been the subject of a lot of conversation and debate between you know, my colleagues and I think the IBD community as a whole. So there are 3 main factors that I could think of that would be related to why we're seeing this increased signal, this potentially increased risk with these agents. And you know, the first may be maybe there's a biologic effect there where somehow these agents are interacting with the immune system and affect the way the virus makes people sick. So that's one option. Another option is that a lot of the times when we've been looking at these medicines, we're looking at them in comparison to people who are on, say, the anti-TNF biologic agents. So it may be that it's actually the biologic agents have a protective effect. So it's not that mesalamine or sulfasalazine makes folks at higher risk, it's that they're at the same risk, and then individuals who are on the anti-TNFs are actually at lower risk. And then the third has to do with something called confounding in our database. And what confounding is that there's an unmeasured factor or something else there that is actually causing the finding that we are seeing, and it's not the medicine itself. And a few potential confounders with the SECURE IBD database maybe have to do with which patients providers are actually reporting to the SECURE IBD database. Because, for example, patients who are on biologic medicines, they have to often go in for their infusions, they interact with their provider more often. So even if they had a mild case of COVID, one would think that it might be more likely that their provider would know that they had COVID and then be able to report that to the registry. In contrast, patients who are on sulfasalazine or mesalamine don't necessarily have to be as in contact with their doctor. So it may be that only the cases where someone is really sick, so they reach out to their doctor, then those are the cases that get reported to the registry, whereas the patients who are on mesalamine, have mild COVID and don't report to their doctor, their IBD doc never knows about it and then they don't get reported. So those are three mechanisms I think could explain this signal, but it's an area of a lot of ongoing research.
I have to say, I just want to jump in and say that our audience is super smart, because somebody brought up the issue of socioeconomic status and the interaction with medicines. So clearly somebody who knows what they're talking about. That's a big issue with SECURE IBD as well, right? Because it's an international network, you know, places where you're more likely to get 5-ASAs medicines instead of biologics may also be the places where people are more poor, can't afford the biologics, have worse access to care, and therefore have worse outcomes with for COVID as well. So there's that interaction between socioeconomic status and access to care and these medicines that it's difficult to control for in this database. But thank you, that's great. So I might pivot to Dr. Agrawal. Any other cautions that you would think of that when interpreting the data from this database that we should be aware of?
I think Erica and Dr. Jones and all of us covered a lot of important ones, mainly being that there is reporter bias in that it's IBD physicians who report these cases. And as Erica mentioned, it's the sick ones that come in contact with the physician, they come to light. And patients who have milder infection may just see their primary provider or may not even see a physician, and they can get missed. So in that regard, it's important to take all of these results and all of these data and put them in context. We don't have a denominator for SECURE IBD, meaning we're just identifying these specific individual cases that are reported to the registry, but we don't know what the pattern is in the underlying population. How many patients tested positive for COVID, how many of them got sick, and how sick did they get? We unfortunately can't capture that data. So it's important to understand that even though this is a really robust registry, and we're so so grateful to all of our collaborators, there are limitations to this registry. And then another important thing to keep in mind is misclassification. All of these data are reported by providers, who review charts and then put in all of the information. So as some variables may change over time, or perhaps, patients certainly know their history better. So it's important to keep in mind that although these data are very accurate, there is a risk of misclassification.
Perfect, thanks. So as we wrap up, we're coming to 8 o'clock. Dr. Jones, just wondering, what are you recommending to your patients now that we're in the height of the second wave now? I know the East Coast is not so much in a second wave, and we're all very jealous, but with a vaccine on the horizon, what are you telling your patients about what to do over the winter?
I call it a second trickle here in Nova Scotia. But essentially, I mean, I'm telling them to double down, right? Because we are heading into the winter, and as Gil says, sort of be the dark winter of the pandemic, and it's going to drive people indoors, more likelihood of transmission, and it's very, very concerning. So I would tell them to double down on recommendations from the Public Health Agency of Canada. Listen to them. Listen in particular to the provincial recommendations by Public Health. And follow them. And certainly when it comes to individuals who are at higher risk, like those individuals we've been discussing throughout the seminar, I would encourage them to consider stepping things up, particularly when it comes to further isolating and protecting themselves during the pandemic. And they should certainly, I often refer them to the Crohn's and Colitis website, in particular to look at some of the risk stratification that's been done by the COVID task force to try to get a sense of what their own personal risk is and what the recommendations might look like. And we really just want to also just hammer home that point that we want to keep them out of the medical system and to maintain any therapies that are currently keeping them in remission.
And as we get close to the end of this webinar, I wanted to address one of the questions that the audience had asked, which is, will IBD patients be eligible for a vaccine earlier than the general population? And I think that's an extremely important question, one that I can't answer today, but we're going to try to answer it with our next webinar. And in fact, the next COVID task force meeting that we're meeting in early December, that Eric and I and Jen is a member of the task force, that's exactly the topic that we're going to be discussing. And often with these task force meetings, we invite representatives who don't necessarily sit on the task force every week, but have expertise to come in to give us some additional guidance. And so we're going to look for those people and ask the questions, should we be prioritizing IBD patients? And if so, how do we advocate for that? Where do we go to make that happen? And so that's something that we want to talk about in our next webinar. So a little bit of a plug for the next webinar, which I believe will be Thursday, December 17th.
Great, and maybe to end us off for both Dr. Agrawal and Dr. Brenner, where do you see the SECURE IBD Registry going over the next few months? How are you going to continue to contribute really important information for the community?
Yeah, so we are excited about a couple of projects coming up. First, we have now opened up our SECURE IBD data to other researchers because there are so many brilliant minds, and we want to make sure that other folks who have really good research questions that can help our patients have the opportunity to use that data to answer those questions. So we have a data sharing process that is ongoing. We have a couple of manuscripts in the works, and that includes the work on disparities that Monsi was talking about, and it includes some more detailed information on different risk profiles associated with different medicines. And then sort of the next phase that we're talking about is, whether it's going to be the role of the SECURE IBD database or a different study to look at long-term outcomes of COVID. So patients with IBD who develop COVID now, will they have worse IBD disease activity? Will there be an increase in other autoimmune type conditions? Or will they be at higher risk of being in sort of the long hauler population? And I think it remains to be seen whether that's going to be a question best addressed by us or in a different capacity.
And also, as our sample size grows, we hope to be able to parse out the impact of other medications which may not be used as commonly, the newer medications, and have a robust sample size to be more conclusive about those. We also hope to, be able to identify trends globally as more cases are reported from different countries, and identify the impact of the different healthcare systems and access to care, etc., in terms of COVID outcomes. And lastly, another thing that we're excited about, which Erica is working on to a great extent, is collaborating with other registries, such as the Rheumatology Registry and the Dermatology Registry, because these diseases are also immune mediated with a lot of drugs that are overlapping. So this way we can have larger sample sizes and learn more from our colleagues. So I think there are a lot of exciting things in the pipeline, and we hope to have more information on these topics.
Yeah, and just one thing to add from a Canadian perspective is we just crossed 50 cases reported in the SECURE IBD Registry from Canadians, with the most common provinces reporting is Ontario and Quebec. And so as Manasi said, as that sample size increases, we can start to potentially look down the road, are Canadians with IBD who get COVID different from other countries? And so I think that would be an exciting project to do from a Canadian lens.
All right, so with that, I think we will wrap things up and say goodnight. I think this was a great conversation. We really appreciate it, and we look forward to having you back next year. when hopefully the SECURE IBD Registry will not be able to report any more cases because we'll all be vaccinated. That would be the ultimate best thing in the world. But realistically, I think in the meantime, at least it's helping us learn more about COVID-19 in IBD patients. And for that, we're very, very grateful. So please do fill out the evaluation. Let us know your feedback. Let us know how you felt this went and whether you have any ideas for future webinars that you want to hear about. As usual, we want to thank frontline workers. I think this hit home a little bit too hard in the past week for two reasons. Number one, we had the first education worker, the first school worker who passed away in Ontario from COVID-19, which was very sad, tragic. But we thank our teachers and our school workers for keeping the schools open. I personally know how important it is as the parent to have schools open, you know, for the kids' mental health and for their development. And to keep the economy going so people can work. So we really appreciate that. We also had our big North American Pediatric GI conference annual meeting virtually this year, last week. And what really hit home is hearing about 3 of my colleagues, pediatric gastroenterologists, who passed away in the past year from either directly from COVID or from complications that arose after COVID. So very sad to see that, you know, even pediatric gastroenterologists are dying from this, you know, even our own. So we thank all of the physicians and nurses and healthcare providers, allied health providers who are on the front lines, especially now when COVID has become much more prevalent in Canada. And finally, as usual, my last plea to, yes, follow us on social media, but mostly really please donate. If you find these webinars useful, if you find the information that we're being provided is useful, while the work is being done by volunteer physicians and nurses, behind the scenes, there's staff at CCC who help put this together, Sarah and Kate and others who are really instrumental in getting these webinars out and getting the web pages up, Angie and others. And, you know, Crohn's and Colitis Canada, like other health charities, have really suffered this year with donations not being able to hold in-person meetings. So we would plea with you, if you find these useful, please donate whatever you can, either on crohnsandcolitis.ca or you can text CURE to 20222. And that'll donate $25 very quickly. I know everybody would very much appreciate it, and the money will go to help with these educational programs as well as for research to find a cure for IBD. So with that, thank you, and we hope to see you back in December for the next webinar. In the meantime, as Mark mentioned, there's lots of educational webinars and symposia happening that Crohn's and Colitis Canada is putting on. Just follow the social media platforms and you'll learn all about it. Have a good month, everybody.
Thanks, everyone.